You know, this is frustrating, but it is medicine, isn't it? It's an art.
It's the art of
It's tricky. Where are we going? Where are we evolving to in terms of the landscape of insomnia? Where are we headed? What do you think?
Well, I think the next step really will be to try to identify where does insomnia come from? What causes it? Where does it start from and why is it there? Because we really have to zero in on the causes, and we're very ignorant about that at this point in time. But I think the second area which we really need to go into is an ability to get into that brain and to be able to calm it down or slow it down without necessarily resorting to medication. And what that is, yet we just don't understand. Interestingly, there's some devices that are coming out that can possibly do that, or at least promise to start doing that. For example, there's a head cooling device, believe it or not,
really?
which has come out. And the data on it are not that dramatic. But the direction is going in terms of being able to globally suppress brain activity. Yeah.
Oh man, that would be interesting. A cold head, warm heart. How do they cool the head?
Well, it's a device, it's a helmet that goes on top of the head, which cools down, and the entire head cools down.
I just have this vision of a big helmet in bed, and it doesn't sound restful to me at all. But I don't know. Look, it's been great. And I don't mean to make light of this. It's a very serious issue. And what's fascinating to me is how much subjective medicine and the art of medicine is involved in this. It's not bacteriology. This is not surgery. This is medicine, and it's tricky. So in the little time that we have before we end this tremendous discussion, I want to give each of you the opportunity to leave us with one thought, one thing you'd like our audience to know. So Dr. Auerbach, why don't we start with you?
Oh, I think that insomnia is maybe too slow, but insomnia is complex. It's not a simple thing. And I think that it's really a labor-intensive effort on the part of a clinician to address it with their patients. And it needs to be addressed, it should be addressed. And the one thing I think that's oftentimes overlooked is that too much emphasis is placed on the sleep minutes, your avatar, and rather than being placed on the patient's quality of life and underestimating the degree of associated anxiety and depression.
Dr. Brandt?
Yeah, I really think it's, especially when we're working with older adults, paying attention to the benefits versus harm. And I'm really doing more studies, looking at comparisons amongst the different agents out there, and really appreciating, even within clinical trials, the use of some of the self-treatment, which I feel is under-identified. But I think we really want to do less harm to our older adult with medications.
Dr. Doug Ramji?
Yeah, if I could recommend one thing, that is try in the workup of the insomnia to, as much as possible, identify the comorbidities and treat them. So be as specific and as targeted in your treatment as possible.
Dr. Johnson, the last word.
Yeah, I go back to one of the things that my mentors taught me, and he said, when in doubt, ask the patient. And what it really means is take the history, which so often is not done, because the history usually can lead you to an appropriate diagnosis, which then the appropriate treatment will follow.
Well, this has just been great. This is not a topic I know that I focused on, but it's something that's really important. And as I look around at the patients and the folks in my social circle, it's something that bothers a lot of people and that we really haven't focused on enough. And I'm delighted to have had the opportunity to do so with you guys today. I want to thank everybody for your contributions, and on behalf of our panel, I want to thank you for joining us. We hope you found this peer exchange discussion to be useful and informative. I'm Dr. Peter Salgo, and I'll see you next time.